Okay, and I will be focusing, just in the interest of time, on myelofibrosis. Won't be talking today about polycythemia vera or essential thrombocythemia. So just a brief background on myeloproliferative neoplasms or myelofibrosis, because for the focus of my talk will be on JAK inhibitors. And I think it's very important to emphasize that although JAK2 V617F is the most common mutation in myeloproliferative neoplasms, we have calreticulin mutations as well as MPL mutations. And although with JAK inhibitors, they inhibit JAK-STAT signaling. Although with calreticulin and MPL mutations, the mutations may not be in JAK2. However, all of these mutations lead to the same downstream activity of activation of JAK-STAT signaling. So just to emphasize that JAK inhibitors are not only for JAK-mutated people. And the clinical consequences of myelofibrosis are quite broad, and I think that's why I find it an extremely interesting disease. It is a mix of a chronic inflammatory condition where, unfortunately, many times myelofibrosis patients can suffer from debilitating constitutional symptoms from increased cytokines. There's fibrosis in the marrow, which can in part lead to anemia, overproduction of blood cells, and extramedullary hematopoiesis can cause splenomegaly, and also patients can suffer from thrombosis sometimes in unusual locations. And the symptoms in myelofibrosis can also be multifactorial. Patients can have cytopenias, such as anemia and thrombocytopenia, which the anemia in part can contribute to their fatigue. However, they generally can have fatigue that is apart from their anemia, potentially driven by high inflammatory cytokines, can also have fever and night sweats, and then the splenomegaly can also cause them some problems such as abdominal pain and early satiety. And I think it's important to note that not all myelofibrosis is the same, and I think that this nomenclature is now coming out into sort of our general discussions of myelofibrosis, that we can think of myelofibrosis in two general categories. Even so, I think this is probably an oversimplification, but can call myelofibrosis, now we have the terminology of cytopenic myelofibrosis, which is somebody who has low blood counts. They're usually somebody with primary myelofibrosis. They interestingly there's left off lower JAK2 or their MPN driver allele burden. These patients have a poorer prognosis and a higher risk of progression, as opposed to the myeloproliferative myelofibrosis patient. That in general is somebody who could be a post-PV patient or a post-ET patient. Those people have more robust blood counts. They have a higher JAK2 allele burden. Sorry, there's some words missing from here. And these people tend to have a better prognosis. So I think the point of this slide is that not all MF is the same. And also, our treatment paradigm for myelofibrosis is a little bit different than the way we think about cancers in general. This is at today's date, our stated goals of treatment in myelofibrosis. Our stated goals are to reduce their spleen size, improve their symptoms, and now with newer medications that are coming out, can try to address their anemia. But I think what's important to note is that we have quite some limitations with our current treatments of myelofibrosis, primarily because we don't necessarily know what exactly disease modification is in this condition. We know they have large spleens, we know they have symptoms, we know that they can progress to myelofibrosis, but what can we do for them to change the trajectory of their disease? And this is a figure from a recent review paper from Naveen Pemaraju, trying to bring up this question about what exactly is disease modification. We actually don't know, but just brings emphasizing that if we are going to have disease modification in this disease modification MF, likely we would need to intervene earlier. And now, just in the past few years, or in the past year, we now have 4 JAK inhibitors. And I think for general practice, probably the most important slide on this whole slide deck is this, and probably the next one, is now that we have 4 JAK inhibitors, when to use which JAK inhibitor in which patient. So ruxolitinib was our first JAK inhibitor that we've had in our armamentarium for over 10 years. Then came fedratinib, then pacritinib, and then just most recently momelotinib. And as you can see, all of them inhibit JAK2, but each has a little bit of a slightly different inhibitory sort of repertoire. Some inhibit JAK1, some don't. I will, just noting that two of the JAK inhibitors inhibit ACVR1, which will be important potentially for anemia. Also important is the side effect profile, highlighting the importance of checking thiamine and repleting thiamine in patients on fedratinib, and in general, as a class effect, can have GI toxicities. And anemia is a significant problem in myelofibrosis and is likely, just as in every component of the disease, multifactorial. But wanted to highlight the potential role of hepcidin in the anemia in myelofibrosis. Hepcidin plays a significant role in the anemia of chronic inflammation, where in response to inflammation, hepcidin goes up, which makes the body not utilize iron. And this is mediated through ACVR1. And interestingly, 2 of our JAK inhibitors, momelotinib and pacritinib, block ACVR1, which is the proposed mechanism by which these 2 medications may improve anemia. Specifically, anemia as a clinical outcome was investigated in the clinical trial that led to the FDA approval of momelotinib, and sort of post hoc analysis of clinical trials with pacritinib may also suggest that. And so now that we have 4 JAK inhibitors, how do you choose a JAK inhibitor? I would probably say that because ruxolitinib has been on the market the longest, probably the majority of myelofibrosis patients living today currently are on ruxolitinib. I think it's still a very good option if the patient has an enlarged spleen, symptoms, and robust counts. Also, physicians are very used to dosing ruxolitinib, so may have more comfort, be more comfortable prescribing ruxolitinib. Pacritinib for first-line treatment is currently approved for patients with platelets less than 50. That's its label, and can be used in any MF patient as a second-line agent. The current label for momelotinib is any anemic myelofibrosis patient without a specific hemoglobin criteria for the anemia. So if a patient has anemia and platelets less than 50, the obvious choice would be momelotinib. But if a patient has anemia and platelets less than 50, you do have the options of both momelotinib or pacritinib. And I think really that's a patient population in which, we don't have great data to suggest choosing one versus the other. And given that we've had ruxolitinib for over 10 years, and so there are a lot of myelofibrosis patients who have been on ruxolitinib for some time. And now that there are other options, can start to think about if a patient has, quote, failed ruxolitinib, what to do. So what does ruxolitinib failure mean? That's a good question. But thinking about it, you can think of different meanings of ruxolitinib failure. Patients can have primary resistance, where they just never responded to ruxolitinib in the first place, their spleen didn't shrink, they didn't have an improvement in their symptoms. or secondary resistance where the patient initially had a response but now is losing it. Intolerance in terms of side effects, probably with ruxolitinib, the most common intolerance would be the cytopenias that are seen, and then progression, increased in blast or increase in spleen size. Want to note that if somebody is progressing to an AML, probably it's not an appropriate option to switch them to another JAK inhibitor. Would really address their progression to AML with a different line of therapy focused on AML. So I will just go over briefly two oral abstracts that focused on JAK inhibitor combos on the horizon, and just wanted to focus on these two because they're probably the most closest to clinical practice. The first one is a combination of ruxolitinib plus navitoclax in the upfront setting. So this study objective was to evaluate safety and efficacy of navitoclax plus ruxolitinib versus placebo plus ruxolitinib in JAK inhibitor naive patients with myelofibrosis. And the rationale for navitoclax in myelofibrosis is quite robust. It's a BCL-XL inhibitor, and BCXL is well known to be upregulated in myelofibrosis, giving it a preclinical rationale. And also in patients who had a previous clinical in patients who were already on ruxolitinib but no longer benefited from it, the addition of navitoclax appeared to the patients derived benefit. So both of the trials I'll be discussing are upfront trials, so JAK inhibitor naive patients. They were randomized in this setting to ruxolitinib plus navitoclax plus ruxolitinib plus placebo. And to emphasize our primary endpoints in myelofibrosis still at this point in time are focused on spleen size with secondary endpoints of being reduction in symptom score and also anemia. And also importantly, adverse events are in particular important for myelofibrosis patients because one of our main goals is to make them feel better. So the last thing that we want to do is give them more side effects. So the waterfall plots that are seen in all myelofibrosis clinical trials, with each of the bars being a patient, there was a significantly higher number of patients on the navitoclax plus ruxolitinib arm who achieved a spleen volume response of at least 35%. And then adverse events, important, as I mentioned, because we don't want to give these people more side effects. It did appear that the combination had a higher percentage of AEs such as thrombocytopenia, anemia, and neutropenia, which I think is important in this patient population. And then total symptom responses were not different between the groups. And so the conclusions in this, I think this was a very important clinical trial to perform of randomizing upfront navitoclax plus ruxolitinib versus ruxolitinib. There were AEs of thrombocytopenia and anemia seen. But preliminary data is encouraging, but I think additional evaluations need to be done to really assess the true value of addition of navitoclax to ruxolitinib. So the next, another very similar trial combining the BET inhibitor pelabresib with ruxolitinib. And this was presented by Rajit Rampal from Memorial Sloan Kettering at this year's ASH. So in this study also took JAK inhibitor naive patients, randomized them to pelabresib plus ruxolitinib versus placebo plus ruxolitinib. And just forgot to put in a slide about the mechanism of action. BET inhibitors have a nice rationale for myelofibrosis. They do reduce inflammation, inhibit NF-kappa B, which theoretically could be quite helpful in patients with myelofibrosis. And so here is the change in spleen volume. The combination of pelabresib plus ruxolitinib had a significantly greater response. And then in terms of total mean absolute symptom score from baseline, there was a strong numerical improvement in the combination, although did not necessarily meet statistical significance. And here's the first one was absolute change in from baseline of total symptom score. This is the percent change. Again, a numerically greater in patients with pelabresib plus ruxolitinib. And this is showing that there were not specific across the board that all symptoms appeared to improve with the combination. It wasn't just focused on particular symptoms, such as spleen-related symptoms. And I think that this slide is kind of a nice way to visualize this, that trying to compare, basically the goal is in myelofibrosis to get your spleen reduced as well as to make your symptoms better. So in 40% of patients in the combo arm achieved both of those goals, as compared to 18.5% of the patients in the placebo plus ruxolitinib arm who achieved both the goals of spleen reduction and symptom improvement. And then because anemia is important in myelofibrosis, this was a secondary endpoint, and they found that there was a numerically greater proportion of patients who achieved a hemoglobin response with pelabresib plus ruxolitinib. So demonstrating that the combination, I think this is an important slide because demonstrating the addition of the second agent does not worsen anemia in myelofibrosis, could potentially actually improve the anemia. And then this slide, I think the inflammatory cytokine plot is more important. As expected, the combination of drug patients had lower cytokines in NF-kappa B related genes, also had lower IL-6 as well as TNF-alpha, as would be expected based on the mechanism of action of the BET inhibitor pelabresib. And then this is fibrosis. I just want to temper this with, there was a oral abstract last year's ASH really calling into question the importance of fibrosis in myelofibrosis. We still measure it, but just wanted to emphasize that there's a provocative oral presentation really calling into question what the real importance of fibrosis and myelofibrosis is, but we still measure it. And then this, I think, is very important because when you're adding a second drug, you don't want to add more side effects. And the addition of the BET inhibitor, pelabresib, led to similar rates of adverse events as compared to ruxolitinib alone. So I think that this clinical trial was there was quite a lot of enthusiasm around it, given that the combination of ruxolitinib plus pelabresib was able to enhance responses in terms of spleen size, greater numerical improvements in symptom score, appeared to have some improvements of anemia without any increase in adverse events. And so where are we headed in myelofibrosis? I think first and foremost we need to define what disease modification is, because if we aim to modify the disease, we need to know what we're trying to aim for. I think in clinical practice right now, tailoring selections of JAK inhibitors to specific patient populations. I have to admit, at this point in time, we have sort of general guidelines, but really it's sort of a guessing game as to which JAK inhibitor is most appropriate for which person. JAK inhibitor combos, I think, are probably the most sort of the one thing that's probably going to come online most quickly, and then novel non-JAK targets, which I didn't necessarily talk about today. So thank you very much.